السلام عليكم ورحمة الله وبركاته. طلابنا اليوم محاضرة حول Hypersensitivity Reaction. كلكم سامعين بأنه بعض المرضى أو بعض الأشخاص يأخذون أدوية معينة يصير عندهم حساسية. بعضهم الحساسية تكون على شكل طفح جلدي، والآخر على شكل حكة، والبعض الآخر ممكن يكون هنالك عدة ضيق في النفس أو تورم في الأغشية المخاطية، وممكن هاي تكون الحساسية إلى دواء معين، أو تكون إلى تعرض إلى مواد في المحيط مالتنا أو أكلات معينة. كذلك أكو حساسية يعني تكون آنية في خلال دقائق، أو تكون بعض الأمراض الحساسية تكون تظهر في بشكل مزمن. راح نتطرق اليوم على this type of diseases, which is the hypersensitivity reaction. What is the teaching objective is to understand the classification of hypersensitivity reaction, to know the disease associated with hypersensitivity reactions, to understand the mechanisms of damage in hypersensitivity reaction to different types, to know the methods for diagnosing conditions due to hypersensitivity reaction, to know the mode of treating diseases due to hypersensitivity and their rationales. Now, what is the definition of hypersensitivity reaction? Hypersensitivity refers to excessive, undesirable, which it could be damaging or discomfort producing and sometimes fatal disease. These reactions produced by the normal immune system. Hypersensitivity reaction require a pre-sensitized state of the host. This means that the subject should have a previous exposure to the same substance that will provoke the normal immune system, followed by the second exposure to the same allergen. So hypersensitivity reaction requires pre-sensitized immune state of the host. Hypersensitivity reaction can be divided into 4 major types, which is type 1, type 2, type 3, and type 4 hypersensitivity reaction. And these based on the mechanisms involved and time taking for their reaction. Frequently, a particular clinical condition may involve more than one type of reaction, as it will be seen later on. Now, what is the type 1 hypersensitivity reaction? Well, also, it is known as immediate or anaphylactic hypersensitivity reaction. The reaction may involve skin manifestation like urticaria or eczema, may involve eyes like conjunctivitis, itching of the conjunctiva, nasopharynx, cause rhinorrhea, rhinitis, a bronchopulmonary disease like asthma, allergic bronchiolitis, and gastrointestinal disease. It may cause diarrhea, gastritis, even gastroenteritis. The reaction may cause from minor inconvenience manifestation to severe and may lead to death of the affected person. The reaction take about 15 to 30 minutes from the time of exposure to the allergen or antigen, and sometimes the reaction may have a delayed onset about 10 to 12 hours. Type 1 hypersensitivity reaction is mediated by immunoglobulin E. which is the primary cellular component in this hypersensitivity, is the mast cell or basophil. The reaction is amplified and or modified by platelet, neutrophils, and eosinophils. So multiple cells may participate in development of such type of hypersensitivity. A biopsy of the reaction site demonstrates mainly mast cell and eosinophils. The mechanism of reactions involve a preferential production of immunoglobulin E in response to certain antigen, which is also called allergen, as shown in figure 1. The precise mechanism as to why some individuals are more prone to hypersensitivity type 1 reaction is not clear. احنا نشوف بين البوبوليشن مالتنا بعضهم ياخذون ادويه معينه يصير عندهم حساسيه، بعضهم الاخرين يعني ما يصير عندهم حساسيه، بعضهم ياخذون اكله معينه يمكن البيض او اي نوع من الحساسيه، تبدا اي من المحسسات الالرجين ممكن تبدا عندهم الاعراض. بعض الاشخاص الاخرين ما عندهم اعراض، كذلك بعض الاشخاص يتعرض الى زرع معين في البستان في الحديقه او اتربه تبدا عنده اعراض الحساسيه، وهذه the mechanism is still unknown one. Possibly it could be related to genetic preference. However, it has been shown that such individuals preferentially produce more of T helper cells that secrete interleukin 4, interleukin 5, and interleukin 13, which in turn favor IgE class switch. IgE is has a very high affinity for the receptor CD32 on mast cells and basophils, and a subsequent exposure to the same allergen may cause cross-link of these cells by the immunoglobulin E and result in the development of the reaction. So cross-linking of these immunoglobulin E on the surface of mast cells results in degranulation of mast cells. تعرفون الماست cells عندها granules. These granules contain a pharmacologically active substances. These pharmacologically active substances is responsible for the development of this type of hypersensitivity reaction. So cross-linking of IgE Fc receptor is important in mast cell triggering. Mast cell degranulation is preceded by the increased calcium influx, which is a critical process. Ionophore, which increase cytoplasmic calcium, also promote degranulation of mast cells, whereas agent which deplete cytoplasmic calcium suppress degranulation. The agent released from mast cell and their effects are listed in table will be shown below. Mast cell may be triggered by other stimuli such as an exercise, emotional stress, chemicals. واحد يصير عصبي يصير يتنك صدره أو يتعرض للبرد، أو بعض الكيميكالز like photographic developers medium الموجودة قرب الأشعة المواد الصبغية، calcium ionophores, codeine, and so on. Anaphylatoxins like complement 4A, C3A, C5A, and so on. These reactions mediated by agent without immunoglobulin E allergen interaction are not typical hypersensitivity reaction, although they produce the same mechanism. هنا الفرق بين ذاك mediated by an allergen وهذا not mediated by allergen. This table shows different types of pharmacological mediator of immediate hypersensitivity reaction. It could be a preformed mediator within the granules or a newly formed mediator. What is the preformed mediator is first the histamine. What is the physiological effect is the bronchoconstriction, bronchospasm, mucus secretion, vasodilatation, and increased vascular permeability. Another mediator is the tryptase, which causes proteolysis, kininogenase, kinin, and vasodilatation, vascular permeability, edema. Another mediator is the eosinophil chemotactic factor A, which attracts eosinophil and neutrophils to the site of reaction. The other form of the mediator is the newly formed mediator, which causes delayed type of hypersensitivity with not an immediate release. It is a delayed type of release, like leukotrienes before, which cause basophil attraction, leukotrienes C4, D4, similar to histamine, but 1,000 times more potent than it. Prostaglandin D2, which cause eosinophil and basophil chemotactic, histamine-like, but more potent edema and pain. And the platelet aggregation factor, which cause platelet aggregation and heparin release. This may cause microthrombi. As we see from this table, there is already formed mediator, which is cause immediate release and immediate type of reaction, followed by delayed release, which is more potent than the immediate release mediator. The reaction is amplified by the platelet activation factors that cause platelet aggregation and the release of histamine, heparin, and other vasoactive amines, eosinophil chemotactic factor of anaphylaxis, and neutrophil chemotactic factor that attract eosinophil and neutrophils, which release various hydrolytic enzymes that cause necrosis. Eosinophil may also control the local reaction by releasing aryl sulfate histaminase, phospholipase D, and prostaglandin E, although this role of eosinophil is now in question. This is a possible mechanism of action. Now, what is the role of cyclic AMP and the cyclic GMP in regulation of the allergic reaction? Cyclic nucleotides appear to play a significant role in the modulation of immediate hypersensitivity reaction. Although their exact function is still not understood, substances which alter cyclic AMP and cyclic GMP level significantly alter the allergic reaction. Thus, substances that increase cyclic AMP, intracellular cyclic AMP, seem to relieve allergic symptoms, particularly bronchopulmonary bronchospasm, and are used therapeutically. Conversely, agents that decrease cyclic AMP or stimulate cyclic GMP aggravate these type of reaction. So this type shows the relationship between the allergic symptoms and the cyclic nucleotide. Lowering the cyclic AMP or elevation of cyclic GMP results in worsening of the symptoms of anaphylaxis, while elevation of cyclic AMP may cause improvement in their symptoms. So, lowering of cyclic AMP can be done by stimulation of alpha adrenergic receptor by norepinephrine or phenylepinephrine, or by blocking of beta adrenergic receptor like propranolol, the commercial name of Enderal. Elevation of cyclic GMP can be by stimulation of cholinergic receptor by acetylcholine or carbachol, and these may result in worsening of the symptoms, while elevation of cyclic AMP can be done by stimulation of beta adrenergic receptor by medication like epinephrine, isoproterenol, salbutamol, and so on, or by blocking of the alpha adrenergic receptor like phenoxybenzamine, or by inhibition of phosphodiesterase like thiophyllene, also by binding of histamine 2 receptor or prostaglandin E to their receptors, and these also may result in the improvement of the symptoms. So how we can diagnose this type of hypersensitivity reaction? Diagnostic tests for immediate hypersensitivity may include skin test like a prick and intradermal injection resulting in a well and flare reaction. This is described by redness and erythema and also induration in the skin area. Also, it can be done by measurement of the total IgE antibody and the specific IgE antibodies against the suspected allergen. This is called the panel test. A total IgE and the specific IgE antibodies are measured by the modification of the enzyme immune assay. Increased level of IgE are indicative of atopic condition, although IgE may be elevated by some non-atopic disease like myeloma or parasitic infections. There appear to be a genetic predisposition for atopic disease, and there is evidence for HLA association. لذلك أنا نشوف بعض الأشخاص ممكن أن يصابون في allergic rhinitis or seasonal allergy أو asthmatic attack which run in families. Other person will be not affected by this allergen. Symptomatic treatment is achieved with antihistamine, which block the main cycle that mediate this type of reaction. So blocking histamine receptor inhibit mast cell degradation, probably by inhibiting calcium influx. Late onset allergic symptoms, particularly bronchoconstriction, which is mediated by leukotrienes, are treated with leukotriene receptor blockage, like Singular, Ecolate, and Leucast, or inhibition of cyclooxygenase pathway. Symptomatic treatment could be done. Although short-term relief from bronchoconstriction is provided by a bronchodilator, such as isoproterenol derivative, thiophyllene elevates cyclic AMP by inhibiting cyclic AMP phosphodiesterase and inhibit intracellular calcium release, is also used to relieve the bronchopulmonary symptoms. IgG antibodies against the Fc portion of IgG that bind to mast cells also has been approved for treatment for certain allergies, as it can block mast cell sensitization and degranulation. Hyposensitization therapy, or we call the desensitization, is another treatment modality which is successful in a number of allergies, particularly to pollens. Still, the mechanisms of action unclear, but it could be related to tolerance induction. The next slide will show us some details about type 1 hypersensitivity reaction, how the mechanism will happen, and what is the pathogenesis that will mediate type 1 hypersensitivity reaction, and the line of treatment of this type of hypersensitivity reaction.
Having a hypersensitivity means that someone's immune system has reacted to something in such a way that it ends up damaging them, as opposed to protecting them. There are 4 different types of hypersensitivities. And in the first type, or type 1, the reactions rely on immunoglobulin E, or IgE antibody, which is the specific type of antibody. The other major ones being IgG, IgA, IgM, and IgD. So because IgE is involved with type 1 hypersensitivity reactions, they're also called IgE-mediated hypersensitivities. This type of reaction is also sometimes called immediate hypersensitivity, because the reactions happen super fast, on the order of minutes. So most allergic reactions are IgE-mediated, and therefore most allergies are type 1 hypersensitivity reactions. Allergy comes from the Greek allos, which roughly means other, and ergon, which means reactivity. Essentially, allergies are reactions to molecules from outside your own body that most people don't react to. And these are specific molecules from things you might breathe or take in, like foods, animal dander, bee stings, mold, drugs or medications, and pollen. But you can also mount an allergic reaction to things you come in contact with on your skin, like latex, lotions, and soaps. These specific molecules are also called antigens, and when they cause an allergic reaction, they're called allergens. An allergic reaction happens in 2 steps: a first exposure or sensitization, and then a subsequent exposure, which is when it gets a lot more serious. People that react to these allergens usually have a genetic predisposition to having overreactions to unknown molecules or allergens. And this means that these people have certain genes that cause their T helper cells to be more hypersensitive to certain antigens. Since the production of these T helper cells is genetically linked, allergies to things tend to run in families. So let's say this person breathes in some ragweed pollen. That person happens to have T helper cells that can bind to a specific molecule on the pollen, making that molecule an allergen. First off, that allergen gets picked up by immune cells hanging out in the membranes along the airways, which then grab the molecule and migrate to the lymph nodes, which happens regardless of if the person's allergic or not. These cells are antigen-presenting cells, since they carry the antigen to the lymph nodes and present it to the T helper cells living there. Dendritic cells and macrophages are examples of antigen-presenting cells. When the person's allergic, the antigen-presenting cell will also express co-stimulatory molecules, which are needed to mount an effective immune response. Before the T helper cell sees the antigen, though, it's called a naive T helper cell, since even though it's built to recognize the antigen, it hasn't actually seen it before. When that T helper cell gets its hands on the antigen, though, and also binds the co-stimulatory molecule, it's now been primed, and the naive T helper cell changes into a different sort of T helper cell. Usually in type 1 hypersensitivity, it differentiates into a type 2 T helper cell, or just Th2 cell. And this step happens in response to various small proteins or interleukins that might be floating around at the time. Some interleukins that sway the T helper cell into turning into a Th2 cell are interleukin 4, interleukin 5, and interleukin 10. And these are all cytokines. and they're given numbers because it's easier to keep track of them that way. At any rate, the excited Th2 cells release a bit of their own interleukin-4 and get the B cells to undergo antibody class switching. And so the B cell switches from making IgM antibodies to making IgE antibodies, which are specific to that ragweed pollen in our example. Th2 cells also release some interleukin-5, which stimulates production and activation of eosinophils, a granulocyte, which is a type of white blood cell that degranulates, or essentially releases a whole bunch of toxic substances that can damage both invading cells and nearby host cells. These ragweed-specific IgE antibodies have a high affinity for, or basically really like, Fc epsilon receptors on mast cells, another type of granulocyte. So they quickly attach themselves to the surface of the mast cells. These antibodies are also called cytotropic antibodies, since they can bind to cell surfaces. At this point, it's like the mast cell's been geared up for combat, and is ready for action, and therefore we're finished with the sensitization phase. Now let's say that that same person breathes in some ragweed pollen again, maybe a few months later, a second exposure. Well, the souped up mast cells, using their coat of antibodies, binds to the antigen. Actually, it takes 2 or more bound antigens to cross-link the IgE antibodies, which signals the mast cell to degranulate and release a bunch of pro-inflammatory molecules called mediators that ultimately causes the effects seen in an allergic reaction. One of the major mediators released in an allergic reaction is histamine. Histamine binds to H1 receptors and causes the smooth muscles around the bronchi to contract, which means the airways get smaller, making it more difficult to breathe. It also causes blood vessel dilation and increased permeability of the blood vessel walls, meaning that while blood vessel diameter increases and blood flow to the affected area increases, fluid is allowed to more easily leak out the blood vessel walls and get into the interstitium, the spaces between the cells, which causes edema and swelling and urticaria, or hives. In addition to histamine, mast cells release other pro-inflammatory mediators, including some that activate eosinophils and proteases, which chop up large proteins into small peptides. The effects of these molecules are called early phase reactions, and they happen within minutes of the second exposure. There are also late phase reactions, though, which happen 8 to 12 hours after the second exposure, where even more immune cells like Th2 cells, eosinophils, and basophils, yet another type of granulocyte, are recruited to the site where the allergen is located because of the cytokines and pro-inflammatory molecules produced during that early phase. These include some of those same interleukins again, interleukin-4, interleukin-5, and interleukin-10, but also leukotrienes, which are smaller molecules made out of fatty acids and facilitate communication between a local group of cells. 2 leukotrienes in particular, LTB4 and LTC4, can not only cause smooth muscle contraction and damage to the epithelium, like histamine, but they can attract immune cells, like neutrophils, mast cells, and eosinophils, to their location even after the allergen is long gone. A lot of people with allergic reactions experience mild symptoms, like hives, eczema, allergic rhinitis, which is inflammation of the nose, as well as asthma. Certain people, though, when exposed to a large load of specific allergens, like with bee stings, seafood, or peanuts, can have a really severe and potentially life-threatening allergic reaction. The increased vascular permeability, along with the constriction of airways, can be severe enough such that the body can't supply the vital organs, like the brain, with enough oxygen-rich blood, a condition known as anaphylactic shock. Treatment for type 1 hypersensitivity can involve a variety of medications. Antihistamines act to block the effects of histamine, which reduces vascular permeability and bronchoconstriction. Also, there are corticosteroids, which can be used to reduce the inflammatory response, as well as epinephrine, which is sometimes given during severe reactions via intramuscular injections through an EpiPen or intravenous injection. Epinephrine can help constrict blood vessels and prevent anaphylactic shock. If there's ever a serious type 1 hypersensitivity reaction that requires something like steroids or epinephrine, it's super important to get medical attention, because type 1 hypersensitivity reactions can be really serious and can sometimes get slightly better before getting worse again. Thanks for watching.
The second type of hypersensitivity is called the type 2 hypersensitivity. It is also known as cytotoxic hypersensitivity reaction and may affect a variety of organs and tissues. The antigens are usually endogenous, but it can be an exogenous chemicals like haptens that can attach to the cell membrane, can also lead to type 2 hypersensitivity reaction. So the main mechanism is the presence of antigen on the surface of the target tissue or organ. Drug-induced hemolytic anemia, granulocytopenia, and thrombocytopenia are such an example. The reaction time usually takes minutes to hours. It is also mediated primarily by the antibodies of IgM or IgG classes and complement. Phagocytic and K cells may also play a role in the mechanism of this type of hypersensitivity reaction. The lesion contain antibody, complement, and neutrophils at the site of the target organs. Diagnostic tests include detection of circulating antibodies against tissue involved and the presence of antibody and complement in the lesion. And this can be detected by fluorescence microscopy. The staining pattern is normally smooth and linear appearance in a fluorescent microscope, such as that seen in good posture nephritis, and this type of disease may cause injury to the lung, and at the same time there will be injury to the kidneys. So there will be depositions of these complex antigen and complement antibody and a complement in the renal and lung basement membrane. Also, another examples is the pemphigus, or we call which is a type of skin disease. There will be a skin intracellular proteins within the desmosome, and this may mediate this type of reaction. So, what is the treatment? The main line of treatment is by anti-inflammatory and immune suppressive agents.
Having a hypersensitivity means that the immune system is reacting to something in a way that damages the body rather than protecting it. There are 4 different types of hypersensitivities. And the second type, or type 2 hypersensitivity, is sometimes called cytotoxic hypersensitivity because a lot of disorders caused by this hypersensitivity involve antibody-mediated destruction of healthy cells. These disorders tend to be tissue-specific, meaning that the antibodies are generally specific to one type of tissue or organ. There are other antibody-mediated hypersensitivities that are systemic, but these are generally type 3 hypersensitivities. So our immune system is set up to fight anything that's considered non-self, right? Anything that's not self, or you. This works in large part because of a process called central tolerance, which is when developing immune cells that are self-reactive get destroyed or inactivated, whereas immune cells that aren't are allowed to survive. And this happens while they're still in their primary lymphoid organs, which is the thymus for T cells and bone marrow for B cells. This process, though, isn't perfect, and some self-reactive B and T cells will escape. These escaped self-reactive cells can then attack healthy tissue, which results in an autoimmune disease. In type 2 hypersensitivity, these escaped self-reactive B cells become activated and produce IgM, or with the help of CD4 positive T helper cells, IgG antibodies that attach to antigens on host cells. And there are 2 types of antigens involved with type 2 hypersensitivity. Intrinsic, meaning an antigen that the host cell normally makes, or extrinsic, which is an antigen from an infection or even some medications like penicillin that gets attached to the host cell. Alright, so let's say a drug like penicillin binds to a red blood cell. Well, it becomes an extrinsic antigen. An IgG, or more rarely, an IgM antibody, that's penicillin-specific might bind to the penicillin molecule, creating an antigen-antibody complex. Now, it's worth mentioning that antigen-antibody complexes can happen in the course of a normal infection, but it's when an antibody is complex to host tissue that things start to become a problem. The first cytotoxic mechanism of type 2 hypersensitivity is activation of the complement system. The complement system is a family of small proteins that work in an enzymatic cascade to fight off bacterial infections using a variety of mechanisms. In this case, the IgG or IgM antibodies activate complement proteins, which ultimately will kill the red blood cell bound to penicillin, which is complex now with IgG or IgM. Alright, so the process gets started with C1, the first of the complement proteins, which binds to the Fc portion of the antibody. C1 then engages other members of the complement family, C2 through C9, some of which are activated by being cleaved or chopped by an enzyme. The cleaved fragments, C3a, C4a, and C5a, act as chemotactic factors, meaning they attract certain cells, in this case neutrophils. Once neutrophils join the party, they degranulate or dump a bunch of enzymes like peroxidase, myeloperoxidase, and proteinase 3, which all help generate little oxygen radicals that are highly cytotoxic to cells and can cause tissue damage. When it comes to drug reactions like penicillin, type 2 hypersensitivity can result in hemolytic anemia, sometimes called autoimmune hemolytic anemia, as well as thrombocytopenia or neutropenia, since these are all blood cell types that are often affected. This mechanism is also involved in diseases like Goodpasture syndrome, where antibodies bind to intrinsic antigens on collagen of the basement membrane in their glomeruli in the kidney, or their alveoli in their lungs, rather than extrinsic antigens in the penicillin example. The second cytotoxic mechanism requires us to follow the complement system through to the end. That said, C5b, C6 through C8, and a bunch of C9 come together to form the membrane attack complex, or MAC. The MAC attacks the cell by inserting itself into the cell membrane, punching a hole or creating a channel that allows fluid and molecules to flow in and out of the cell. And this is not good for the cell's overall health, right? Because due to the osmotic difference, fluid rushes into the cell, and the cell swells and eventually bursts, called cell lysis, and it dies. And that's the second mechanism, and this is where the name cytotoxic comes from. In our example, if you suspect autoimmune hemolytic anemia, the antibody in question can be detected using a direct Coombs test. In the direct Coombs test, the person's red blood cells are separated from the plasma and then mixed with Coombs reagent, which is anti-human globulin, basically an antibody against human antibodies. If the red blood cells agglutinate or clump up, that means that they probably had antibodies on their surface. Besides a direct test, there's also an indirect Coombs test, which is usually done to check for blood group incompatibility. For an indirect Coombs test, the patient's serum is mixed with laboratory red blood cells that have known antigens on their surface, and then once again mixed with Coombs reagent. If there is red blood cell agglutination, that indicates the presence of antibodies or complement in the serum. The indirect Coombs test is done to determine if you have antibodies before you're exposed to the antigen. For example, this could be like a mismatched blood transfusion, or a second pregnancy with a mismatched Rh factor between the mother and the child. Alright, so the third cytotoxic mechanism of type 2 hypersensitivity happens when IgG antibodies coat a blood cell that are bound by C3b, another one of those complement protein fragments. At this point, we say that the cell has been opsonized, which means it's targeted for phagocytosis, which is where they get engulfed and destroyed by phagocytes like macrophages and neutrophils. Once opsonized, the antibody-antigen complex in the cell it's attached to encounters a phagocyte in the body's blood filtration organ, the spleen. And the phagocyte targets the cell by binding to the Fc tail of the antibody or the C3b bound to the IgG. Then it engulfs and destroys the cell. Alright, so the last three mechanisms involve the complement system in one way or another. The last couple mechanisms are a little different. So the fourth mechanism is called antibody-dependent cell-mediated cytotoxicity, or ADCC. In this case, the bound antigen-antibody complex gets recognized by immune cells called natural killer cells. The natural killer cell recognizes the Fc tail of the antibody and releases toxic granules. These granules contain perforins, which, just like the MAC, form pores in the cell, except that this time the pore also allows entry of enzymes that are like these silent assassins called granzymes, as well as granulysin, which work together to cause cell death in an apoptotic or quiet death sort of way, such that there's no surrounding inflammation. Okay, so far all the mechanisms have led to cell death or cytotoxicity, right? There are, though, non-cytotoxic type 2 hypersensitivities as well, where the antibody just sort of disrupts function, called antibody-mediated cellular dysfunction. Sometimes when an antibody binds to its antigen, it just sort of gets in the way. When this happens, it can change the way the cell is supposed to function. This is the case in the autoimmune disease myasthenia gravis, where antibodies specific for the acetylcholine receptor in muscles simply blocks the binding of acetylcholine, which causes the muscles to not get stimulated and progressively weaken over time. This mechanism is also involved in Graves' disease, where antibodies target receptors that stimulate thyroid hormone production. But in this case, they not only get in the way, they actually activate the receptors, causing overproduction of thyroid hormone, or hyperthyroidism. And there you have it, a handful of different ways that antibody binding to cells can cause them to get destroyed or become less effective. The important things to remember about type 2 hypersensitivity is that they're antibody mediated, they generally lead to cytotoxicity, and they're tissue specific.
The third type of hypersensitivity reaction we call type 3 hypersensitivity, also known as the immune complex hypersensitivity. The reaction may be general, like serum sickness, or may involve an individual organs, like involvement of the skin, example systemic lupus erythematosus or Arthur's reaction, or involvement of the kidney, example lupus nephritis, lung, as in case of aspergillosis, blood vessels, as in polyarteritis, joint, like rheumatoid arthritis, or other organs. So there will be a specific organ involvement by immune complex the mechanism. The reaction may be the pathogenic mechanism of disease caused by many microorganisms. The reaction may take about 3 to 10 hours after exposure to the antigen. The best example is an Arthur's reaction. It is also mediated by a soluble immune complex. They are mostly of IgG class, although IgM may also be involved. The antigen may be exogenous, like a chronic bacterial or viral or parasitic infection, or endogenous, like non-organ specific autoimmunity. The best example here is the systemic lupus erythematosus. The antigen in this type of reaction is soluble and not attached to the organ involved, as seen in type 2 hypersensitivity. So the main differences in the solubility of antigen is in type 3 hypersensitivity, the antigen is in a soluble form and there will be deposition after formation of antigen antibody with the aid of the immune complement system, while in type 2 hypersensitivity there will be insoluble antigen and the attachment within the surface of the target tissues. The primary component are soluble immune complex and the complement, which may include C3A, 4A, and 5A. The damage is caused by platelet and neutrophils, as it will be seen in the next figure. This figure shows the mechanism of damage in type 3 hypersensitivity reaction. The lesion contains primary neutrophils and deposit of the immune complex and complement component. Macrophage infiltrate in later stage and may be involved in the healing process. The affinity of antibody and the size of immune complex are important in the production of the disease and determining the tissue involved. Diagnosis involve examination of the tissue biopsy for deposit of IgG and complement by a fluorescent microscopy with the aid of immunofluorescence test. The immunofluorescent staining in type 3 hypersensitivity is granular as opposite to the linear type of type 2 hypersensitivity reaction. The presence of immune complex in serum and depletion of the complement level also are diagnostic. Treatment may involve the anti-inflammatory agents.
Having a hypersensitivity means that someone's immune system has reacted to something in a way that ends up damaging them, as opposed to protecting them. There are 4 different hypersensitivities, and the third type, or type 3 hypersensitivity reaction, happens when antigen-antibody complexes deposit in blood vessel walls, causing inflammation and tissue damage. Alright, so first off, type 3 hypersensitivity reactions are mediated by immune complexes. Immune complexes, aka antigen-antibody complexes, are made of 2 parts, the antigen and the antibody. Antibodies, sometimes called immunoglobulins, are produced by plasma cells, which are basically fully matured and differentiated B cells. Initially, these cells make IgM, which can be secreted or bound to the plasma cell surface where it acts as a B cell receptor. When a B cell undergoes cross-linking of 2 surface-bound IgMs, it then takes up the antigen and presents a piece of it to T helper cells via T cell receptor to the MHC class II molecule presenting the piece of the antigen, along with co-stimulatory molecule CD4. The B cell CD40 also binds to the T cell CD40 ligand, and then the T cell releases cytokines, which result in B cell activation and class switching, or isotype switching, where it changes the type of antibodies it makes. In type 3 hypersensitivity reactions, typically B cells switch from making IgM to making IgG antibodies. Now remember that all antibodies are specific, right? Meaning that they recognize specific molecules called antigens, the second part of immune complexes. Antigens can come in all sorts of flavors. Some float around in the blood by themselves and are soluble, but some are bound to cell surfaces. Immune complexes are formed when antibodies bind to soluble antigens. Antibodies can also target antigens on cell surfaces, but these aren't considered immune complexes. And this is the first major distinction between type 2 hypersensitivity reactions, which involve antibodies binding to antigens on cell surfaces, and type 3 hypersensitivity reactions, which involves immune complexes with soluble antigens. A good example of a type 3 hypersensitivity is the autoimmune disease systemic lupus erythematosus, also just called lupus. In lupus, the IgG antibodies are typically specific for DNA and nucleoproteins, both of which are part of our own cells, making them self-reactive. Normally, your body should only react to things that are foreign, or not self. And this is maintained by a process known as tolerance, where only non-self-reactive B and T cells are allowed to mature, whereas self-reactive B and T cells aren't. This process, though, isn't perfect, and sometimes some self-reactive cells can escape. And these can mount an immune response against autoantigens, or self-antigens. With lupus, a DNA autoantigen might get released from a damaged cell, and a circulating self-B cell might find it and bind to it. If a T helper cell that's also specific for the same DNA autoantigen is close by, it'll help activate the B cell and enable it to differentiate into an IgG secreting machine, specific to that DNA autoantigen. Now what? Well, first off, there might be lots of this DNA autoantigen around, since DNA is in most human cells, right? Which allows a lot of IgG DNA autoantigen complexes to form. Now, if this were an infection, there'd be a lot of antibodies surrounding a large single microbe, which marks it for destruction by macrophages and other phagocytes. But in this case, the antibodies are trying to bind to a small, soluble antigen, and and there might be lots of antigen relative to the number of antibodies. Small antigen-antibody complexes are less immunogenic, meaning they're less attractive to macrophages, and they don't get removed from the bloodstream as quickly. As a result, the immune complexes float around in the blood longer, and typically make their way to the basement membrane layer of various blood vessels. Once deposited, the immune complexes activate the complement system, a family of 9 small proteins called C1 through C9 that work in an enzymatic cascade to clear infections in various ways. In this case, C1 binds to the antibody-antigen complex, which sets off a chain reaction and activates C2 through C9. When a complement protein becomes activated, it's often cleaved or chopped by an enzyme, which results in little fragments. Fragments C3a, C4a, and C5a are anaphylatoxins and increase vascular permeability, meaning fluid leaks out more easily, which causes edema or fluid buildup. And this is the second major distinction between type 2 hypersensitivity, where complement proteins are activated in relatively small amounts, and type 3 hypersensitivity reactions, where complement proteins are rapidly consumed in large amounts, specifically C3 and C4, which means that the complement levels in the blood can be used to track disease progression over time. The second thing C3a, C4a, and C5a do is act as chemokines, meaning they recruit other cells like neutrophils to the site. Now, once neutrophils join the party, they try and phagocytize the immune complex, but usually they can't. During this process, they degranulate, meaning they dump a bunch of lysosomal enzymes and reactive oxygen species which cause inflammation and tissue necrosis, which ultimately causes vasculitis or inflammation of the blood vessels. With inflammation comes further cellular destruction and more autoantigen release, repeating the cycle again. This most commonly takes place in areas like the kidney, where the blood's being filtered, causing glomerulonephritis, as well as the joints, since blood plasma is being filtered to produce synovial fluid, and this causes inflammation of the joints, or arthritis. And this brings up a third major distinction between type 2 hypersensitivity, where clinical symptoms correspond to the tissue where antibodies attach to and destroy cells, and type 3 hypersensitivity, where clinical symptoms correspond to the tissue where immune complexes are deposited, not where the immune complexes are made. Now, another example of a type 3 hypersensitivity reaction is serum sickness, which typically happens when a patient receives foreign serum and elicits an antibody response against those foreign antigens. A classic example would be to get bitten by a snake and then get serum with anti-venom antibodies. In response, the body would make some antibodies against the anti-venom antibodies. Now, if that person gets bitten by a snake again sometime later and gets the serum with anti-venom antibodies again, those antibodies that were made the first time around will bind up and make immune complexes with the anti-venom antibodies, which are now being treated like an antigen. These immune complexes then cause vasculitis and tissue necrosis, which would ultimately teach a person not to play with snakes.
The fourth type of hypersensitivity reaction is type 4 hypersensitivity reaction. بعض زميلاتكم ممكن تعاني من type 4 hypersensitivity reaction، خاصة من نشوف بعض الزميلات يلبسن ساعات معدنية فيكون أثر على الجلد، أو بعض الأحيان لبس التراتشي نشوف dermatitis حول التراتشي. So this type of hypersensitivity can also known as a cell-mediated or delayed type hypersensitivity. The classical example of this type hypersensitivity is the tuberculin skin test or Montox. The reaction that peak about 48 hours after the injection of the antigen, it is usually the PPD or protein purified derivative when injected into the subcutaneous tissue. The lesion is characterized by induration and erythema. The size of induration may reflect the severity of the disease. Usually, skin induration more than 12 millimeter is indicated of active infection. Type 4 hypersensitivity is involved in the pathogens of many autoimmune disease and many infectious disease. The best example is the tuberculosis, leprosy, blastomycosis, histoplasmosis, toxoplasmosis, leishmaniasis, and so on. And there will be development of granulomatous lesion. So there will be development of granuloma lesion due to chronic infection and foreign antigens. Another best example for the type 4 hypersensitivity is the contact dermatitis like poison ivy, chemicals, heavy metals, in which the lesions are more popular. Papules will be formed at the contact area. The type 4 hypersensitivity reaction can be classified into three categories depending on the time of onset and a clinical and histological presentation. And this will be shown later on table 3. So the mechanism of damage in delayed hypersensitivity reaction include T lymphocyte and monocyte and or macrophage infiltration. The pathogenesis is triggered primarily by helper T1 cells that secrete cytokines that will activate and recruit macrophage to the local area, which cause a bulk of the damage to the involved area. The delayed hypersensitivity lesion mainly contain monocyte and T cells. The major lymphokines involved in delayed hypersensitivity reaction include monocyte, chemotactic factors, interleukin 10, and gamma interferon, and tumor necrosis factors. This table shows different types of delayed hypersensitivity reaction. As I mentioned, there will be a contact dermatitis, tuberculin, and granuloma. The reaction time for contact dermatitis is about 48 to 72 hours. The clinical appearance will be as a case of eczema. The histology pattern within the lesion is the lymphocyte, followed by macrophage, edema of the epidermis, the antigen, and the site is the epidermal area. The second type is the tuberculin skin test. This reaction is the time of the reaction is about 48 to 72 hours, described by local induration at the site of the injection. In histology, there will be a lymphocyte, monocyte, and macrophage infiltration. The antigen is the intradermal injection. The best example is the tuberculin and lepromine test. Another form is the granuloma formation, and this is the longest type of type 4 hypersensitivity reaction. It takes about 21 to 28 days. There will be a hardening within the skin. The histological appearance will be the macrophage, epithelioid, and giant cell with the development of fibrosis. This is due to persistent antigen or foreign body and the presence at the target area. The best example is for tuberculosis and leprosy. The diagnostic tests is in vivo include delayed cutaneous reaction for Montauk's test, and the type is the patch test for contact dermatitis, and in vitro tests for delayed hypersensitivity include mitogenic response or lymphocytotoxicity and the production of interleukin 2. The mode of treatment is by corticosteroid and another immune suppressive agent used. This table shows comparison of different types of hypersensitivity reaction. In the first line, we see the characteristics of the antibody, and on the horizontal lines is the types of the hypersensitivity. First, the antibody in type 1 is the IgE, type 2 is IgG or IgM within the cell surface. Type 3 is the soluble form or complex with the IgG and IgM antibody. There is no antibodies in type 4 hypersensitivity reaction. The type of antigen in type 1 is exogenous, type 2 is surface, the type 3 is a soluble form, and type 4 is tissue and organs. The time required for the development of hypersensitivity for type 1 is about 15 to 30 minutes. Also for type 2, about minutes to hours. Type 3, 3 to 8 hours. And type 4, 48 to 72 hours, even longer. The appearance in type 1, appearance of well and flare. Type 2 is lysis and necrosis. Type 3 erythema and edema and necrosis. Type 4 is erythema and induration. What about the histological appearance? In type 1 is the basophil and eosinophil infiltration. Type 2 antibody and complement. Type 3 complement and neutrophils. Type 4 macrophage and T cells. The transferred with antibody, type 1, antibody, type 2, antibody, type 3, and T cells for type 4. The best example for type 1 is the allergic asthma, hay fever, type 2 erythroblastosis fetalis, and good posture syndrome. Type 3 is the SLE and farmer lung disease. Type 4 is the tuberculosis, poison ivy, and a granuloma. The last video shows the details about the type 4 hypersensitivity reaction.
Having a hypersensitivity means that someone's immune system has reacted to something in such a way that it ends up damaging them as opposed to protecting them. There are 4 different types of hypersensitivities, and in the 4th type, or type 4, the reactions are caused by T lymphocytes, or T cells. And so type 4 is also sometimes known as T cell mediated hypersensitivity. T cells are called T cells because they mature in the thymus. And the 2 types of T cells that cause damage to tissues in type 4 hypersensitivity are CD8 positive cells, also known as killer T cells, or cytotoxic T cells, as well as CD4 positive T cells, also known as helper T cells. CD8 positive killer T cells do exactly what their name implies. They kill things. They're these silent assassins of the immune system that go after very specific targets. In contrast, CD4 positive T cells locally release cytokines, which are small proteins that can stimulate or inhibit other cells. So CD4 positive T cells act like little army generals coordinating immune cells around them. But both CD8 positive and CD4 positive cells start off as naive T cells because their T cell receptor, or TCR, hasn't yet bound to their target antigen, which is that specific molecule that it can bind to. All right, so let's play out a scenario. Let's say someone's skin brushes up against some poison ivy. They'll get this molecule called urushiol all over. That molecule is small enough to quickly make its way through the epidermis to the dermis, which is where it might combine with small proteins, and then it might get picked up by a Langerhans cell, also known as a dendritic cell, which is a type of antigen-presenting immune cell. The dendritic cell then takes it to the nearest lymph node, the draining lymph node, where it presents the antigen on its surface using an MHC class II molecule, which is basically a serving platter for CD4 positive T cells to come check out. If a T helper cell recognizes the antigen, it binds to the MHC class II molecule using its T cell receptor, as well as CD4, which is a co-receptor, and this is why it's called a CD4 positive T cell. At this point, the CD4 positive or helper T cell will also express a CD28 protein, which will bind to the B7 protein on the surface of the dendritic cell. Once it binds to the T cell receptor and the CD28 protein, the dendritic cell releases interleukin 12, a cytokine that tells the naive CD4 positive T cell to mature and differentiate into a type 1 helper T cell, or a Th1 cell, a sort of coming of age moment. At this point, the CD4 positive T cell is no longer considered naive. Instead, it's an effector cell that's able to release the cytokine interleukin 2, which helps both it and other T cells in the area proliferate, as well as interferon gamma, which activates phagocytes like macrophages and creates more Th1 cells. Those activated macrophages release pro-inflammatory cytokines like tumor necrosis factor, interleukin 1, and interleukin 6, which causes leakiness in the endothelial barriers and allows more immune cells into the area, all of which leads to local swelling or edema, redness, and warmth, as well as systemic symptoms like a fever. Activated macrophages will also secrete lysosomal enzymes, complement components, and reactive oxygen species into the exposed area, which damage tissue. In the case of poison ivy, since this is all going on in the skin, it's called dermatitis, inflammation of the skin. This kind of contact dermatitis rash doesn't only happen from poison ivy, though. It can also happen in some people in response to wearing nickel, which is often found in earrings and necklaces. And another classic example is a tuberculin skin test, sometimes called a PPD, which is where a protein from the bacteria Mycobacterium tuberculosis is injected into the skin. If that person's been exposed to TB previously, they'll develop a type 4 reaction, where TB-specific Th1 cells will migrate to the injection site and create an inflammatory response that results in the skin getting thick or hard, called induration. The type 4 hypersensitivity is also sometimes referred to as a delayed type hypersensitivity, since it usually takes about 48 to 72 hours to recruit Th1 cells to the site of exposure. So these skin reactions usually appear over that time window. Apart from skin-related reactions, though, type 4 hypersensitivity is also involved in several systemic diseases like multiple sclerosis, where Th1 cells damage myelin around nerve fibers, and inflammatory bowel disease, where Th1 cells cause inflammation in the lining of the intestine. In addition to Th1 cells, a naive T helper cell might differentiate into Th17 cells, which is just another subclass of T helper cells. These Th17 cells develop in response to dendritic cells secreting slightly different cytokines, interleukin 6 and transforming growth factor beta. When that happens, the resulting Th17 cells are formed, and they produce interleukin 17, which is particularly important to recruiting neutrophils. Alright, so that was helper T cells, or CD4 positive T cells. But remember that in type 4 hypersensitivity, damage to tissue can also be caused by killer T cells, aka cytotoxic T cells, aka CD8 positive T cells. And these destroy cells directly. CD8 positive T cells target antigens when they're presented on MHC class I molecules, which are present on all nucleated cells in the body, meaning every cell is a potential victim for a CD8 positive T cell. MHC class I molecules present antigens from inside the cell, so this process is important for when cells become infected with viruses or when they're mutated, like with cancer. If this were to happen, then an effector cytotoxic T cell specific to that antigen would use its T cell receptor to bind to the MHC class I molecule, which would cause it to release its payload of perforin and granzymes. Perforin would perforate the target cell by forming pores, and these pores would allow the granzymes to enter the cell. Once inside, the granzymes induce apoptosis, or programmed cell death. Diseases where this cytotoxic mechanism is involved include tissue destruction in type 1 diabetes mellitus, where CD8 positive T cells attack pancreas islet cells, as well as Hashimoto's thyroiditis, where CD8 positive T cells attack thyroid epithelial cells. So, as a quick recap, type 4 hypersensitivity leads to inflammation and tissue damage via T cells, which can be either CD4 positive T helper cells, which help coordinate the attack, or CD8 positive killer or cytotoxic T cells, which directly do the attacking.